California, where we are recording. I'm a cardiologist and physician scientist and help run our augmented clinical intelligence program, and on the coordinating committee for the AIM-HIGH program. So it's my distinct honor and pleasure to introduce our speaker and discussant today to discuss Dr. Munoz's project on diabetic retinopathy screening using point-of-care artificial intelligence. So Dr. Fatima Munoz de Flores is the Associate Vice President of Health Support Services with over 15 years of health promotion and research experience focused on epidemiology and implementation of health prevention programs, specifically among underserved communities. Fatima has extensive experience engaging in a variety of public health issues and building strong bridges between public health, government, and academic leaders on both sides of the US-Mexico border. Her recent research is focused on chronic and infectious disease epidemiology and the impact of binational access to care on health policy. Fatima also has experience examining health services utilization and the potential of health technology integration into existing health services in order to improve treatment adherence and reduce the burden of high priority diseases such as diabetes, TB, and HIV. And she is the recipient of one of the AIM-HIGH grants, which we're going to hear about today. And we're very fortunate to have as our faculty discussant, Professor Alistair Dennison, who is a professor of regulatory science and innovation at the University of Birmingham and an honorary consultant ophthalmologist at University Hospitals Birmingham NHSFT. He is a leader in the field of artificial intelligence and digital health technology and co-leads the AI and Digital Health Group, a research and policy group focused on responsible innovation of AI health technologies. So just before we begin, I just want to remind folks that the next session will be on September 12th at the same time slot. And we'll be discussing the project Precision Resuscitation with Crystalloids and Sepsis. But without further ado, I will hand off the meeting to Dr. Munoz. I look forward to the discussion.
Thank you, Dr. Solomon, for your kind introduction. I'm trying to share my screen, but I don't see that function.
At the bottom, it's a little green arrow at the bottom of Zoom.
Is not.
Sometimes you need to minimize the screen and get blocked by the toolbar at the bottom if you change the size of the Zoom. Not seeing it.
Sorry, I still haven't. I only can see that one participant here, but it's not showing the other. So, okay, go ahead. It's not. So I apologize for that, but I saw.
No worries.
Yeah, sure.
Caitlin, do we need to make Fatima a host or?
She is not right now.
She should be able to.
Yes, so I tried.
Oh, there we go.
We got it.
All good.
Again, I'm so sorry for that.
Oh yeah, no problem.
No.
It's always something, right?
And that was the reason that I practiced right before the presentation. Thank you, Sonia. Team effort. I apologize again. So good afternoon, everyone, and thank you for the opportunity to present our study, Diabetic Retinopathy Screening Point of Care Artificial Intelligence, and the AI in Clinical Intervention at Ysidro Health that evaluates the impact of modifying our existing clinical practices with the integration of AI-based technology for diabetic retinopathy screening to improve patient care. This is our wonderful group of study investigators. Our team reflects the important collaboration of an interdisciplinary group of medical, research, and AI technology and clinic operation experts that I hope that everybody is here today also to represent the three organizations with San Ysidro Health, the UC San Diego, our research, academic, and evaluator partner, and INAC, our AI technology subject matter experts and partners. So this is a real and truly collaborative effort. This chart represents the structure of the complete team with the leadership, the research operations, evaluation, technology systems, and communication. So you can imagine that all the different levels that have to work to put a project like this with this nature. As you know, diabetes continues to be among the top causes of morbidity and mortality, affecting 11.3% of the US population, and diabetic retinopathy is a common complication. Diabetic retinopathy is a leading cause of blindness among working age adults, affecting 9.6 million of people in the US. And according to the CDC, it is expected to affect approximately 14.7 million of people living with diabetes by 2015. And this particularly affects people between 55 and 79 years old, male, Black and non-Hispanic and Hispanic. There was reported higher prevalence rates according to estimates based on the 2021 population. Diabetic retinopathy, as you know, is symptomatic, even at advanced stages, from all the way to normal, to mild, moderate, and severe non-proliferative and proliferative diabetic retinopathy. Therefore, routine screening is critical for early diagnosis and timely treatment to reduce the risk of vision impairment, making blindness preventable. So this is where we wanted to act. Although the current standard of care for routine eye exam actually is available, there are important individual and structural barriers that have contributed and continues contributing to a very low diabetic retinopathy screening with the rates between the 35 to 60%. For example, at San Ysidro Health, our organization, our screening rate is about the 47%. Most of our patients are referred outside San Ysidro clinics to the eye specialist for their annual screening. Then this opportunity to integrate the point of care AI technology screening is a real opportunity to see and how this can be integrated in our clinics that represent a unique and innovative opportunity to address unmet medical needs and diabetic eye care, enhancing our existing clinical practices. Just a little bit about San Ysidro Health. As a federal qualified health center that was established in 1969, our commitment is to provide high quality of care that is compassionate and accessible. We are always looking for strategies that are aligned with our mission and our commitment with our community and patients. Our name and brand's identity represent the humble beginnings in the community with our founding mothers, 7 women in search for medical services for their children. San Ysidro Health Leading Safety is a leading safety net provider of critical primary care services and the second largest community health center network in San Diego County. According to our records in 2023, we serve 160,000 patients, and this provided services either in person and or virtual visits. Our patients really prefer the in-person contact. It's a high-touch model for our population. 85% of patients lived out below 200% of the federal poverty level. A third were children, and some proportion similar, a third were seniors. So here is where we can see what the opportunities to implement programs to support our population. Our clinic sites, we provide medical, behavioral health, dental, medical specialty services, and we also support services such as case management, nutrition, social services. And we also have special programs, including research opportunities for our patients to be part of. Across San Diego County, we provide services throughout the robust integrated network of 50 sites, including 26 health centers, so you can see the distribution, and countywide for urban and rural communities. And also we operate 4 mobile clinic units. And here I'm highlighting the location of the 2 clinic sites that host our DRES-POCAI study, Chula Vista and King Chavez. Among San Ysidro patient population, we have 12% have diabetes, and their screening rate, as I mentioned before, is 47%, very low. And in the table, you can see also characteristics by, the sites, specifically the clinics where we are going to be conducting the study, where still the diabetes retinopathy screening rate is very low as 46%. Therefore, this research study really represents a promising and sustainable practice to address the growing need of diabetic retinopathy prevention, early diagnosis, and treatment that can be disseminated and escalate to the scale up to the primary care settings as well. Particularly for this study, we are using the practical, robust implementation and sustainable model to guide our overall study design and approach. PRISM considers multi-level and dynamic context when implementing and evaluating an intervention's effect using the reach, effectiveness, adoption, implementation, and maintenance, the REACH outcomes, to evaluate the implementation and how this works. Our study considered barriers and facilitators of diabetes care at Ysidro Health, what we currently have, particularly resources, preferences, and constraints of the clinics to inform selection of the multi-component AI intervention with the three main components: the point of care AI for DR screening, the integration of the systems with the AI system and the medical record, electronic medical record, and also very important, the patient education and engagement. We expect this intervention will result in improved implementation and DR screening clinical outcomes through an integrated primary care workflow, improved care cascade, and patient self-management. Very specific, our study has two aims: the co-design part, the evaluation, the pre-implementation piece, and the trial. Our first aim is focused on optimizing and refining our multi-component intervention and implementation with physicians, clinical staff, and patients, introducing autonomous DR screening integration in primary care before the implementation of the AIM-2 or the trial. This first part of the study of the project was led by Dr. Nicole Stanley, that I am presented as part of her behalf, from UC San Diego, with a collaboration of our wonderful San Ysidro research team. For this, the AIM-1 co-design, we use an innovative qualitative method called brain writing premortem. This method invites implementation partners to pre-identify possible reasons an intervention might fail, and to co-create solutions before its implementation. The team conducted 7 virtual group interviews in English and Spanish, with the participation of 12 San Ysidro Health patients and 11 providers and clinical staff with the clinical team. They received $50 gift card, and the interviewer guide included possible reasons why this new DR screening program might fail, and also potential solutions that participants identified to address those failures. The findings, solutions, and implementation plans from the interviews have been adopted for the research stage, and some of them will also be adopted following the research stage or during full San Ysidro or the program's implementation. And some others were not deemed necessary to address at either stage because will require more evaluation. This work, the AIM-1 co-design findings, are in preparation for publication and led by Dr. Stepnick as well. So the qualitative analysis involved the rapid thematic analysis approach to inform pragmatic and actionable refinements to the intervention and the implementation strategies. The final things, and this is very important because it was a very dynamic process related to the potential failures and solutions, were presented to the full team to prioritize which strategies can be feasible and immediately addressed, and to develop revised implementation plans before they actually launched the trial. Overall, there were 24 failure themes identified and 62 solutions to address the perceived potential failures of the screening program. Of those, 45, approximately 73% of the solutions have been adopted prior to the implementation. 19% are kind of pending that will be addressed for later adoption, and only 5 really will not be adopted because we'll need a little more work based on the nature of those concerns. And here you can see some of the characteristics of the participants for this particular program step. Here are some highlights from the group discussions. These are examples of the concerns that our team have addressed, like how can we address the patient hesitancy towards new technology and AI, language barriers, staff confusion about the roles and delineation in the clinic. This is new. No show rates and later arrivals, how this will affect the medical visit, space and exam rooms, referral process, anxiety over receiving the negative or complete results, because this is definitely, this is new again. and the patient and provider communication. And also some delays in that because the screening can also impact the medical care. Confusion about the comprehensive yearly eye exam, patient preference for the exams by provider. Again, our population prefers that high touch. Scheduling challenges and also clinic, even technology connection, internet connection. So all of these kind of concerns have been addressed. You can also see some kind of examples of the voice of the participants that are aligned with this type of the concerns as well. Here, and finally, are some of the examples of the concerns that we're still, working on and planning to address after the project, or the project implementation or even the research. And because of the nature, there are some of them that we are not going to be able to address, the lack of clinical decision-making, or the IR, the technology that we are using, the system, and also some other related with the insurance as well. Now, transitioned to the next part. It is a pleasure for me to introduce my wonderful colleague and expert, Sonia Tucker, who is the Vice President of Population Health for San Ysidro Health and co-principal investigator of the DRES-POCAI study. Sonia has been working for federally qualified health centers over a decade. Sonia's work has led to improvement in health center organizations, and she has worked for achieving numerous of quality of care recognitions from organizations such as the National Committee for Quality Assurance and the Health Resource and Service Administration, and many, many, many more. Thank you so much, Sonia, and you're taking from here.
Thank you very much, Fatima. I just want to make sure everybody sees my screen. This one right here, not the one.
Yes, we can see it.
Okay, perfect. Perfect. Well, thank you very much. Well, I get the pleasure to really talk a little bit about the integration and the technology that we have done to be able to take this project to the next step. So I want to make sure that, why do we choose this particular intervention? So autonomous AI technology for diabetes retinopathy screening is feasible given that this technology requires minimal operating training, minimal disruption in the clinical workflow, and its FDA clear AI system is accurate and reliable. So those are the areas that we took into consideration before we move forward with this intervention. Okay, so I want to make sure that also I share with you guys, it's not like there was no information before we started using, or we proposed to use this particular solution. So it has been demonstrated during multiple large independent studies and pivotal prospective clinical trials that IART, which is the organization that we're working with and the technology that we're using, has a high sensitivity and specificity for identifying more than mild diabetic retinopathy as well as vision-threatening retinopathy. During the prospective trial, it was also demonstrated that IR sensitivity is superior to the dilated eye examination. And that is demonstrated right here in this particular slide that I'm not going to read to you guys, since I know all of us can see this information right here. So I want to also take you guys to the next step is, what have we done internally? So there are three components that are important for the DRES-POCAI intervention. These three components are the integration of the new point of care autonomous diabetic retinopathy screening into San Ysidro Health primary care workflow, which is the first area that you guys see right here. The second part is the integration of the interface that we established between IART and San Ysidro Health EHR system via an HL7 interface. And the third one is the patient education and engagement, which is based on evidence-based information. The idea is to promote diabetes self-management among our patients. So the next step is, how have we worked with this technology? So for diabetes retinopathy screening in this project, we have proposed to use IART, which is an FDA clear AI technology, which is a point of care detection. The idea behind using IART is simple: enables non-specialists such as our primary care provider to screen diabetic patients for diabetes retinopathy, which is asymptomatic in many cases until very late, as you guys know that very well. Patients undergo retinal imaging, which typically does not require dilation in this particular case, and can be done by anyone with a high school diploma, which is something that is very important. The report is available within 30 seconds. It is really fast, and the patient will receive, and in our case, we give a copy to the patient, and the information goes directly to the patient's chart for the review by the provider. And this we can see right here is how we are able to see kind of an area how we look into this workflow. Here is a little bit more of details on the workflow. So the whole idea here is the IR is incorporated within the clinical workflow in San Ysidro Health with a tight ER integration. As I said before, initial 7 interface. Once the patient has been registered at the front desk with the PSR, so the patient service representative, the diabetes retinopathy screening order is placed by standing order that we're leveraging within the clinical workflow. A technician pulls that information in their work queue. Within that, so we identify the right patient, the right order, and the technician proceeds to take that particular the particular pictures for the patients. These retinal color fundus images are then sent for analysis and discrete analysis, and the results are sent back to our EHR, where the appropriate referral is triggered. There are 4 possible outcomes for this particular examination, and those 4 outcomes are here on the right side. Either the patient is completely okay, is negative, the possible ungradable might be that the patient is mild to moderate diabetic retinopathy positive or visual-threatening retinopathy. And we're going to talk a little bit about what are the different outcomes that we're going to follow after the provider sees what the results are. So in the DRES-POCAI EHR integration, we have a few areas. So the first area are what are the screening and equipment that we have chosen. So San Ysidro Health has decided to go with a TRC NW400 camera, which is a non-myodratic retinal camera. And that camera was chosen because it's easy to use, it's reliable, and is really it's amazing to really use. And it was part of our team, the one that decided to use this camera. So the important part right here is how it is easy to use, and the middle part is how we have trained our staff to be able to take this particular screenings. And the last part is how we're able to see within the camera. And this is the information that gets sent directly to the IR technology. So here we are seeing the EHR integration and the pre-screening process. So here's the first steps of that. Our staff is able to start an encounter by an order a standing order. The order will use an IR diabetic retinopathy exam in fact, let me just go real quick right here. So in the visit taskbar on the left-hand side. And then on the bottom side they're able to complete this. The second step will be to produce an order that will appear in the shopping cart. And lastly, the person that is placing the order needs to tie the correct diagnosis with the diagnosis have been already placed for the team right there to choose, which is easier for them, so they don't have to think about what diagnosis they're going to be using. The screening process, we have decided to do it via pictures. So the first picture right here on the top left-hand side is how it looks like. On the right-hand side is the right-hand side and the bottom left-hand side are how we are screening one of our patients. The middle picture is one screen, a real screen, and the right-hand side is the result. This is how it looks on the technology part. The fourth part is of this EHR integration is the diabetes screening results and how the provider is able to see those results. The results they can be seen in the chart when the provider reviews it. We have established a link right here for the provider to see the images, or it can also be in the in basket, and it will be if you guys can see right here, if it's abnormal, there's going to be a little red check mark on the top to call the provider's attention, and the provider will be able to immediately see what the results are. And the results are being seen on the right-hand side, and they're able to see it. If they want to see the images, they will have to get to the link. And this is how the images are going to look like for the provider as well as for the patient. We're giving the patient this particular example. So lastly, the EHR integration is the automatic referral. Within the automatic referral, we have established a way for the technology to be able to identify what is the diagnosis, if it's a mild to moderate visual-threatening retinopathy. So a referral is placed and started within, if it's a mild to moderate, it's 48 hours for us to process because it's an urgent referral. If it's a stat referral, it's because the patient has a vision-threatening retinopathy. And this is automatically all coded within our EHR for the provider to be able to start to be able to complete the process. So we are leveraging the technology so the provider doesn't have to do this. The only thing that they have to is just approve. And that is my part. And I wanted to introduce now, I'm sorry, Edgar, you want to take over? I want to introduce Edgar. Edgar is the co-PI and is the director of the Research and Health Support Services. Edgar has more than 20 years of experience in research and has been working with Ysidro Health for the past 3 years. Edgar has been able to implement large studies and groups where he has been very successful. Thank you very much.
Okay, thank you, Sonia, and good afternoon, everybody. I'm gonna now present what is the aim 2 for our project, which is the actual DRES-POCAI intervention, the randomized clinical trial that we are doing to evaluate the efficiency and the effect of this screening in our community. So as part of this aim 2, we have some hypotheses. And is one of them we're expecting just because of the improved access to care, the improved access to the screenings to have an increase in the number of screening of rates of diabetic retinopathy in the community, at least by 10%. As you saw from Fatima, numbers like screening values for us are in the low end in these specific clinics. Also, we expect to see an increased number of complete referrals to the eye specialists, and increase established early stages of diagnosis of diabetic retinopathy, just because we're going to have the screenings in the clinic and we will be able to send patients right away without the need to do lengthy referrals and follow up with appointments that can fall somewhere into the process. With this, we expect that diabetic retinopathy complications will be diminished due to the early treatment and early identification that we are doing with the system. Also, because we have a component that is a health education component and some patient navigation accompanying the patient, we expect greater knowledge, attitudes, and self-efficacy from the patients. Also, patient satisfaction just because of the support that we are providing through this process. As with in any research study, we have different areas that we are working on. So there is some stages that happen pre-randomization, some happen after the randomization, and this is just to show you some of the different groups that we are doing, some of the different stages that this happen. We have put in place all the reporting, all the information to get the eligibility, so we can identify what patients are eligible, and we'll show you that. And then there is some chart reviews, screening calls, new screens with the patient just to make sure that they qualify, and the recruitment part. Once we consent patients, we are doing baseline information so we can compare the knowledge and the attitudes that they have with after the project. Randomization, we are using a randomizer app so that the patient feels a little bit more in control, not like pre-assigning a list that some of them might say, oh, why I go through an hour of this process if you always knew that I was going to be usual care. So I think that's a way to give a little bit of control for the patient and feel that they're part of the process. Our power calculations identify 848 patients as the sample size that we needed for this project. So we are expecting to have 424 patients in each one of the groups. For the intervention group, this is the group that we are doing the screening at the point of care. These patients going to have immediate results available that we are handing it to them. They're also going via the EHR to the provider, so they can discuss whatever questions they have, and they can have the guidance that we need. For us, that part is important. And these patients also getting a component of a patient education during the visit session, and also a follow-up session that will happen within 6 months, so they can learn to manage their diabetes in a better way, and also some follow-up so they can complete referrals and appointments. For the usual care group, these will also have all the same patient education and care management components, but they will be just referred to the eye specialist as they will be in the usual workflows that we have right now. We're going to be following a lot of data, both from surveys, from the EHR, just following up the completion of these referrals, the result of the patient seeing the diagnosis, and just trying to see which the completion rates for both ends. As for inclusion and exclusion criteria for the study, we try just to align those to the needs of the IR system. Now, of course, we want patients that are established in San Ysidro, that have diabetes. There is the age requirement due to by the definition of FDA of being adults, and those patients that have a medical appointment and have not had a retinal exam in the last 11 months. So if the patient had a screening 2 months ago, probably it doesn't make sense to enroll it in the study because they are already compliant. And exclusion criteria is those patients that already have diabetic retinopathy. There is no point to include them. Some other complications that will make the IR system not feasible or not ideal for them to be screened. And when we look at the numbers, when we try to see how this come in the real life, in the real world, we have 31,676 patients that are active patients of San Ysidro in intervention sites. So those patients that's called our clinics, the medical home. And from those, 15.28% of them have diabetes. So this is 4,840 of them. And you see, this is higher than what is the US average and even the San Diego County average. But it's what we expect for this mix of the population. This is not controlled by race, ethnicity, or anything. That's just the total number of the patients in the clinic. When we look at the demographics, we see that 62% of them are female, 21% of them are white, 6% are Black African Americans, and 79% of them are Hispanics. So this is the bulk of the population that we see in this specific area of the county in the clinics that we're seeing. And this English and Spanish, just to show you, because we have our approval right now to go into English. We're waiting for the approval in Spanish for recruitment. Those are the two materials that we have at the beginning, but that covers 98% of the population that we're seeing. When I told you about some of the inclusion and exclusion criteria, when we remove the patients that don't meet some of these criteria, that they did not meet the inclusion criteria, they're younger than 22, or they have some of the conditions that you see, you can see the universe in some of them. Some of the patients will have 2 or 3 of these conditions, but when we see total number of non-eligible unduplicated patients, we are removing 1,198 patients from these. Just note that some of the pathologies that we have, ocular injection, laser treatment, or some of these treatments that make somebody non-eligible, we don't see any patient. It's not because they don't exist, it's just because the granularity in our medical record systems don't exist, because these are conditions that are usually treated outside of San Ysidro, not inside, so sometimes the information doesn't transfer. But when we do some chart reviews and we talk to the patients, we can identify some of these patients. Also, patients with mental or neurodegenerative disease, that these are patients that cannot really consent to the study. We see a very small amount, basically, because some of these patients just look for a different level of care and not inside San Ysidro necessarily. So with this, we have 3,648 patients that are eligible for the study in the 2 clinics. And the demographics, as you see, they carry forward very similar to the overall demographics of the diabetic patients in the clinic. But we know that there is a lot of very dynamic criteria, like not having a diabetic retinopathy screening in the last 11 months, patients that have a PCP appointment on the next 2 weeks. Those are the patients that we are recruiting, Those are the patients that we are calling, because we just want to make sure that they have the support, seeing the provider to discuss their like some of the results in case they need to have follow-up. And this is just a snapshot of the kind of report that we have from EPIC that we can run at any point. And for instance, in the next 2 weeks, at the moment that I took this, there were like 422 patients that had the appointment. So this is actually the number of patients that we have to call to invite in a single week. 360 of them were due for the screening, but just note that only 90 of them have a last date. So there is not, sometimes we don't have enough visibility in some of our medical records, and it's just transitioned to EPIC recently. So some of the data is not there yet. So we need to do a lot of manual screenings to do this. And it comes to all these calls that we have to start making and all the chart review, no? So this is the realities when we implement a program. We just got a approval recently for the IRB, so we just started in the last 2 weeks to start doing some of these calls to invite patients. We identified 103 patients in these last 2 weeks to invite to the program. 49 of them, like half of them, were non-eligible once we review the chart, so we talked to the patients. So it takes a little bit of a manual process, but also it has been helpful information for us to refine the reports, to find new ICD-10 codes that we need to include to our eligibility criteria, and also for improved processes that we are using for documenting this. And you can see the split there and some of the outcomes, no? Like some of the patients, yes, they are declining, and some of them are interested, but they want us to call later. We have so far, this is, as I said, this is week 2. We have fully enrolled 2 participants. One was randomized into the intervention group, one into the control group. And we have 3 more appointments upcoming during the week. And what we found is the very first patient that we enrolled, that it was an elderly participant, a very cooperative, like a very nice person to deal with. It was ungradable. No, we tried to take the picture several times, but just because comorbidities, other issues that she has, it wasn't the reality. It was ungradable, and we have to refer it to per protocol to an eye specialist, and we have confirmed that the referral was made and the appointment was made. The participant that was in usual care also completed all the processes, and it was referred, and we have also confirmed that the referral was completed. And this comes to where we are and what we are doing. So this is basically our timeline, our revised timeline after we have almost 2 months delay to get the IRB approval in English. We were expecting to start in July. We have our approval the last week we're starting in June, and we got our approval at the last week of July. So we're just getting started, and we expect to do enrollment in the next 6 months, between August and 2024 and February of 2025. No, but all of these happen, all the AIM-1, all the integration, all these happen in the first few months. We are waiting right now for approval for materials in Spanish that will open our study to 80% of our population. So we are basically right now more like hindered by the inability to reach out to Spanish participants. The following 6 months after that, we'll get to do the follow-up survey that is part of the protocol. So we're going to be calling patients. We're going to be providing another health education class. And also we're going to be asking about some of the same questions, just to see what the difference is between pre and post intervention. And then we're going to be inviting, this a little bit separate, like some of those patients that had a negative screening using the IR system, to have a follow-up screening and just do some participant surveys, just to make sure that they still like it. No, maybe that some of the participants, they're happy to go back and use AI to do the screening. Some of them might want to see a person, or so just trying to understand that. And then we have a more compressed timeline to have the some of these analysis, but we expect to have papers out by February. And I think with this, it becomes also the some of the sustainability of the project that we're going to be working and see what will be if this is this works well for us, how we're going to expand this to other clinics in the inside Ysidro Health, how we're going to make the process sustainable in the long term. And with that, I will go back to my colleagues and open the floor for discussion and questions.
Thank you, Edgar. Thank you, Simona. Thank you, Fatima. Amazing talk. Really excellent to see the work that you've been able to undertake. So just a couple of questions from me, and then we'll open it up to everybody. If, as Matt has put in the chat, if you could put questions in the chat, then I'll distribute them to our brilliant speakers. So as you look at the trial so far, one of the things that is always interesting in these with these sort of interventions is how much you do this on a per patient kind of consent opt-in basis. So to recruit individual patients, very much in a traditional clinical trial for like drugs, etc., versus how much you put in a whole pathway change and maybe randomize. Sometimes it's in clusters in the sort of institutional level, etc., and sometimes in a whole screening program. It'd be great to hear your thoughts about, when you were wrestling with the trial design here, you'll have thought through all these things, and there'll be good reasons for the design you've chosen. So let's hear about that, please.
And I can start, but when you can complement. Actually, that was one of the big discussions that we have at the beginning, no? Should we just randomize by clinic, make this available to some of the clinics and not to the patients? But I think for us, like the true science will come to look at exactly the same population. We have several clinics across different parts of the county of San Diego. And some of them, even though we have similar populations, the populations are different enough just because different race, different ethnicity, different age, and different beliefs, no? So we thought that it would be probably a cleaner approach for us to make this available to two clinics that we thought that were representative, and then just randomize within the clinic. And this will be the beginning, no? We know that once this research phase stops 6 months from now, that we finish like all this recruitment, we can make the systems available to the clinic from what we have learned, no? So that was part of the process.
Yeah, and do you have, I mean, this is always a challenge. So on the one hand, you can have the relatively purist, we can pick patients who fit within these strict inclusion criteria. Again, that echoes more like a drug trial versus a little bit more of the kind of messy real world where maybe we have a less selected group. And one of the things that we've sometimes seen in studies like this is the danger of the kind of bias, the selection bias that happens because of who says yes to doing studies. Sonia, Fatima, I see you nodding. One of you want to respond to either of those points?
Definitely. I'm eager to talk about this topic because it was really a lot of communication discussions, serious discussions, because as you can imagine, having the head of the FQHC, right? So our mission is to provide patient care, and we are also putting in the dilemma of it's a patient care, but it's also we wanted to strong and real evaluation with a trial that without that strict evaluation that the design of the study can provide us with the possibility to have this evidence that can help us to even scale up and going in the correct way. So it's not easy. It has not been easy because of the data, because of the population that we serve as well. So, but we do have experience collaborating with other partners in the academic institutions doing the individual, level 101 randomization. And we kind of acknowledge those challenges as well. And that was the reason that at the beginning, even if it was very easy, for one way to say, to implement in the real world operation, the clinics, they just let's go with the cluster by clinic, just go there. However, we are gonna be missing a lot of the information that at the end, only the individual level can give us a little more real evaluation and data for inform the future practices. So I'm glad that at the end we had like the two worlds, the clinical operations, practicality, also patient care, but on the other side, the science, right? So the evaluation and what the opportunities you have in the two worlds. So we have been very fortunate to have a wonderful colleagues of Marva, Dr. Marva, that is also in the call, and Nicole with the three groups with INOC as well. It has been a lot, again, conversations, but it's not going to be easy. This is what we can see it. But it's definitely worth it, because as part of our plan is the sustainability transition to the clinic operations. So then we wanted to continue evaluating that, recognizing some challenges that we have right now because of limitations of the research study, but we also can anticipate those challenges even in the real world and the clinical practice as well. And that's why we incorporated the co-design piece that is informing a lot that what will be the real clinical operation world as well. So not an easy answer, because that is exactly the real world challenges when you have this AI technology, not only the research concept, it's in addition to that, the use of technology with the AI and to be translated into the clinical daily operations.
Thanks, Fatima. And actually, that's a really good reminder that, you know, with any of these evaluations, there's the kind of headline results, which, you know, I think we often focus on what's the result of technology, but studies like this, you know, you have so many kind of deep questions running underneath it, which are really powerful. You know, we look forward to seeing those reported as well.
Dr. Dunstan, and let me just kind of add, because we went back and forth on this, and again, as I think Fatima mentioned, we had to really work with our colleagues on, you know, making what was the right decision. So, and I'm big in implicit bias, and I think implicit bias is very, is something that we have to be aware. So, being in a federal qualified health center, we have the fortune, if you will, to have a very diverse population. So we had to kind of think about what are the best sites for us to try to really place this within the medical workflow, because we knew we were going to do individual randomization. So how can we overcome that implicit bias that any study with individual randomized trial will have, by really choosing the right size that we thought was going to give us a little bit of that cushion to be able to overcome some of that implicit bias that naturally will be there. So for us to try to overcome. So I think that the two sites that were chosen were purposely for that reason. So that way we could, okay, we're not saying that we have all the answers, but that's one of the areas also that we looked a lot. I think that was the part that took us a little bit longer to really figure out and be all in agreement for.
Thanks, Sonia. And actually, just in case we run out of time, just to say to all three of you, you know, it's an exceptional project, and you know, it's a real privilege for us to hear about it. And I know all the those involved, as many of the others on the call were, with the selection of the projects that were awarded. They're all very high class, impactful projects, and it's really exciting seeing it coming through. So well done. There are a few questions in the chat that I'd like to come to now. And I won't read them all verbatim, but Amwava Rogers, thank you for that. Is there a collaboration opportunity? We're currently working on a funded NIH project under DSI Africa and Uganda. And she points out so many of the similarities. So I'll leave you to pick that up with her directly. Thank you. Matthew Lin, this is a good question. I don't know if you can answer this off the cuff. How much did this implementation and clinical trial cost? I know Medicare FFS has begun to reimburse for AIDR diagnosis, but is there any other revenue argument for the added operational cost? And the second question, just in passing, you may be interested. So there was a big review in the UK looking at different AI for diabetic retinopathy, and IART was the one that came over with the best cost effectiveness evidence at the time. That's a year or two ago. So it's interesting you went for the same technology, but yeah, any comments on the kind of
Yeah. I want to start with the comment. I will let Edgar to do the piece of the cost of the implementation. That's his part. But for me, I work a lot with our payers, and in the UK, Dr. Dennis is a little bit different because of the way that you guys have your medicine. So here, yes, here. So let me for Matthew. So as a federally qualified health center, we have a little bit of a different methodology in how we get reimbursed. So the methodology is PPS rate, which is a prospective payment methodology that is a very complicated formula that they do. So what we have decided to do for the study, as well as this is how we're trying to implement it in real life as well, after the study for sustainability, is to include these actions within the medical clinic, with the medical visit. The medical visit is reimbursed within the PPS rate. So there is a reimbursable. Because we're a federally qualified health center, we do not get reimbursed as a fee for service for actions such as this one. It is included within that capitation or that PPS rate methodology that we have. But because we knew that was the case, that's what we're proving that the workflow, the inserting this within the clinical workflow has minimal interruption of the workflow, so that way we can use this as one of the vital signs that the patient is taken during their visits. So that is what we're trying to see if we can do that, so that way we can make it self-sustainable. In regards to the second question, which is assisting burnout with clinicians and ophthalmologists, that is what we're trying to do, because what we're trying to make sure is that the provider will use technology to aid the decision making of that particular provider, so they don't have to do. That's why we have inversed some quotes in there, so everything is automatic for the patient, for the provider, as well as for the patient. So that's what we're trying to prove with this intervention. Edgar, I don't know if you have the cost of the clinical trial.
Yeah, I think the cost of the clinical trial is relative, no? I can tell you, like, when we all know how much these awards were, like $750,000, but that's not only that, no? There is a lot of costs that were related initially, of course, to buying the system, to licensing of the system, that probably they will vary by location. So I don't want to give a number here that maybe is not accurate. But I think all the things that are related, all the support that we receive from San Ysidro Health, like from the executive level, like if you think the cost of the implementation for all the IT integration, for everything, because we have INOC as our partner, like all these many hours that were put into IT, I don't know that we have quantified them, no? And all the support that we have from different levels of expertise in different departments. So it's not only the cost of like what the grant is or what we're expecting or what the budget was. I think the cost at least doubled when you put like finding the space, like getting everybody involved. So you really need the support from the organization that is going to implement the program, and it has to be a priority for them, because if it's not a priority, spaces and all the things that need to fall into place, and all the support that you need to get, data reports. And I say IT has been a very significant piece for us, and the support that has been provided by the organization. So that is difficult to quantify when you add all the number of hours and different people.
Yeah, thanks. And it's very hard addressing that cost effectiveness argument in kind of isolation and a short question like that. But thank you, Rudy. Interesting one also, sort of part two from Matthew. Has this technology implementation assisted with burnout for the ophthalmologist clinicians? I'm imagining it's pretty hard for you to respond to that yet, but do you want to put any comments on that?
So we have worked with, I have to say, and I think that ties very nicely with the following question about, are they happy? What are they doing? It's, it's like any new shiny toy, right? So it's kind of exciting to have it. We are hopeful that's what we're trying to figure. That's what we're trying to do. We don't want to put one more thing just because it's the next shiny toy, because it's what we're talking about. It's the new thing, it's the new word, the artificial intelligence. That's not what we're trying to do. What we're trying to do is we feel our patient population deserves the best quality of care. Just because they're lower income, they don't deserve any less. Totally opposite. We talked a lot about equity. So how can we give this patient the best care possible? And if leveraging technology is one of those ways, I think I am very positive that we will be able to help the providers to save some time, as well as just eliminate that burnout, because placing one referral, and that particular referral needs a follow-up, and that follow-up needs an action plan, and so forth. That is what is really accumulating the work for the provider, and the burnt out comes right after that. So if we have that patient with the results right there and there, the provider they don't need another appointment with the patient. So they will be able to have a more successful or a more informative visit and an action plan right there. So hopefully that's what we're trying to do. The same thing with the ophthalmology. If the patient has a diagnosis which is a mild to moderate or a vision-threatening retinopathy, we want to send those patients directly to the specialist versus going to the ophthalmology of the optometrist that works with us, so that way we can direct the patients to where they need to go. So we will be saving one appointment for that particular patient. We will be opening access for other patients that need to be seen with less problems or less eye problems for that particular ophthalmologist or optometrist that we have internally.
Thanks, Sonia. I'm thinking we're coming close into land, just in terms of timing. Can I just check, Dr. Solomon? Do we have time for any more questions, or are we coming to close?
I think that we could probably just do Marilyn Harris's question, which I can read off. Please summarize the response to the patients and other providers on the use of AI in the procedure. Were they excited, curious, happy, or otherwise?
I can respond quickly and summarize. So overall, there was an excitement. There was definitely thinking and patient care. There were some kind of questions, and more than logistically is more the concern about patient care, because this is very specific for diabetic retinopathy screening. So is not replacing the comprehensive eye exam. So even though we can see this as a huge opportunity for our patients to expand a little more the capacity in terms of point of care, because we have the patients right there, we don't want to continue missing those opportunities. There is always kind of in the bottom line and saying that, but we can kind of overpromise what this technology and what this exam and this screening can do, because we still need our patients to complete the comprehensive eye exam. That basically has been more the focus on the continued conversation. But through the solutions, there were some other ways to also address that, just keeping the communication, keeping the engagement with the patients and also with providers, and utilize the chart, the EA chart, and that obviously that integration to remind. But that has been honestly the only one. In terms of excitement, is a positive, willing obviously to support. But for providers particularly, the concern was more about patient care, and then not having the patients to miss that or just assume that this screening will replace the comprehensive eye exam for the identification of other pathologies that is important for this population as well.
Excellent, thank you. I know that one of you wrote again about potential collaboration opportunity. I would encourage you to get in touch directly with the investigators, discuss offline. Alethea, do you want to close us out, or shall I?
Yeah, thank you so much, everybody. Great session. And thanks, Dr. Solomon, for coordinating, and Dr. Dennison as well. And thank you for our speakers. We will be posting the recording of the session and the slides in the coming days on Health AI Partnership website under the events webpage. And please follow us, and we hope to see you in the next Real World AI Symposium series. So the registration link is in the chat, so please make sure you join. Thank you so much.
Thanks, everyone. Bye-bye.
Thank you.
Thank you. Bye.